Okay, welcome. March 4th, 2026 Q&A with Dr. Wong. Thanks for joining us, Dr. Cheng. Some questions. Feel free to submit your questions in the Q&A box, but let's get started with some pre-submitted questions already.
Okay. Hi. I notice some parents with Class 2 Division 2 dentition have children with Class 2 Division 2 dentition. Is this genetics or environmental? I suppose it depends on who you ask. So the current stance for our profession in dentistry, in orthodontics, is that all skeletal um, relationships are inherited. That the um, genetic determinants override all other aspects, and whatever occlusion a child develops and finishes with is what they're born with. The dental relationship can be altered through environmental factors, but the skeletal relationship is predetermined. So that's the current stance for our profession. We are focused in postural orthodontics with the belief system that all the systems that we have used in the past to try to alter skeletal growth has been proven to be ineffective. We accept that all current systems that have been used to date, because they failed to alter skeletal relationships, that the genetic etiology makes sense. What we do in postural orthodontics, however, is fundamentally completely different to almost every other orthodontic approach that has been done in the past. Orthodontic approaches to try to change skeletal growth has been based on functional appliances. Postural orthodontics is focused on altering the child's posture. So most functional appliances act very similar to orthodontic mechanics. Orthodontic mechanics often is spring related or elastic related, and you're pulling one jaw towards the other jaw through the action of opening the mouth. In postural orthodontics, we're focusing on making changes through teaching a child to keep their mouth closed and held closed at rest. The reason why we focus on posture is from John Mew's work, Peter Bouchain's work, and Geckel's work, Bjork's work on posture, having a greater influence than function. Prophet made it very clear with his work on the difference between function versus posture. And we have shown through appliances such as Frankel appliances and new BioBlock appliances that in small scale of treatment for specific individual clinicians, there has been success in altering skeletal growth patterns. Control of vertical, control of AP has been possible by a small number of clinicians. That change is attributed to environmental factors being equally powerful. Excuse me, just one moment.
Sorry, I didn't mean to interrupt your meeting. Sorry, I was here yesterday to talk about yeah, taking on the rights in the building.
Okay, so yeah, please do submit your questions. Thank you, Dr. Cheng. I've got your question. Let me just add that to the mix. Okay, got those added. If anyone has any questions for me, any logistical questions, I know some of you have joined tonight, are part of the case study vault. Just wanted to let you know that we have added the transcripts of the entire course from our 2-day intro to our advanced training, phase 1, phase 2, lab day, clinical day. They're now added in the top section, as well as the case study vault, the entire transcripts of every video, so you can search things a lot easier. All right, Simon's back. I'm going to unmute him. Okay, I've just...
Okay,
There you
sorry
go.
about that.
No worries.
Plus, if we look at basic physiology and biology, so basic sciences, we actually know the environmental component of growth and development, in particularly with the mandible, after the age of about 18 months, is actually more influenced by the environment than genetics. So if we look at it from the perspective of the pure sciences, we know that the profession's reliance on the concept that growth and development of the jaw is primarily genetic based is actually false, but we've made it what we advocate because we actually have been unsuccessful with our attempts to alter skeletal growth. So something to consider. From the perspective of what tends to be genetically predetermined, John Mew did mention that he believed muscle growth, development, and potential has a much stronger genetic basis than mandible and maxillary growth and development, which is much more dependent on environmental factors. So we know that our genome expression is a combination of both genetics and environment, but there are too many potential variables from growth and development of the jaws for it to be controlled purely by genetics. The fact that we start with no teeth and then 20 primary teeth, which then over a course of 10 years change over to 32 adult teeth that are supposedly meant to intermesh perfectly together. It's just too many variables to allow for a purely genetic predetermination. Environmental factors have to come into play with so much variation in growth and development. I'll give you one more thought to consider before we finish off with this. We know for bony development, synchondrotic growth is a genetic-based growth and development. So synchondrotic growth traditionally is in long bone, so the length of your long bones or your ultimate height is predetermined by very tight genetic factors. Synchondrotic growth is the primary driver of growth and development of the mandible for the first 16 months of your life, postnatal. We also know that secondary growth sites, such as periodontal ligament, temporal mandibular joints, alveolar bone, are environmentally stimulated growth factors, right? They're not genetically determined growth factors. We also know that after about 18 months of your initial childhood development, all synchondrotic growth in your mandible stops and is superseded by secondary growth sites. So mandibular growth from 18 months of age until maturity is not driven by synchondrotic growth, but is driven by secondary growth sites. If we know synchondrotic growth is the genetically expression of growth, but secondary growth sites such as periodontal ligament, TMJ, dental alveolar bone, is environmentally driven, then how can you say the growth of the mandible is genetically driven if physiologically between 18 months to 18 years of age, it's completely environmentally driven? All right, so I'll call an end to that particular question. Next question, does everyone grow into class 1 or does it depend on facial type? For example, does a narrow face have a tendency to develop into class 2? Does it depend on muscle tone or is it 100% determined by environmental habits? Or is there a genetic tendency that makes someone more likely to develop class 2? So again, if we look at the genetic tendency, if we look at it from pure physiological and biological growth, so basic sciences, we know our growth is genetically predetermined until about 16, 18 months of age, after which environmental factors take over, specifically in mandibular growth, so that it is adaptive growth to breathing, mastication, speech, and dental eruption and development. If that is the case, and if we understand that muscle development has a much stronger genetic tendency, then you're going to have a foundation which is to some degree predetermined genetically. But after 18 months of age, environmental factors take on a very powerful role in facial growth and development. So does it mean that you can be influenced by genetic factors? Of course, your first 18 months of postnatal growth and all your prenatal growth has a huge impact on how you will develop into the future. But consider that from 18 months onwards, environmental factors have an amazingly powerful influence. Then where you are at 18 months, the switchover from genetically driven growth to environmentally stimulated changes will have a big influence. So we know syndromic children, right? Children with a genetic defect, very often cannot have a foundation that is optimal in balance. All right, so very rarely do we get syndromic children with class 1 growth, so to speak, by the time they hit 18 months of age. But if we're talking about the 95, 98% of other children who are non-syndromic, then at 18 months of age, where they kind of end up is the stepping stone foundation of where they're going to develop into the future. How is it that these kids don't just grow into class 1 and that we end up with all variations of class 1 crowding and spacing, and then some end up class 2, some end up class 3, some end up with excess vertical growth? The adaptation in secondary growth sites is to fundamentally breathing, mastication, speech, and dental development, and ultimately the resting posture. So things that upset the breathing, things that upset the speech, things that upset the eating apparatus, things that upset the dental development, things that upset the posture, will alter the growth from that potential of good balance to imbalance. Next question. In a perfect world, if a pregnant mom were to ask what I would recommend she does to help her baby grow as healthy and develop as possible dentally, what can you tell her? It's always difficult for us to give any form of advice for pregnant moms and even nursing moms. It's just not a field that we have any license to really discuss. We don't have the knowledge, we don't have the training. My personal advice, and it can only be taken as personal advice, would be to eat real food and to avoid fake food. Mothers should provide nutritional needs that are consistent with what we historically have needed as human beings. And, until the last 200 years prior to that, almost everything that we ate was from the land or the sea. And today we seem to be eating foods that come from factories that are ultra processed. So I would say stay clear of ultra processed make-believe foods. I'm an advocate for protein as primary food source, but that's just a personal opinion. Animal proteins tends to be a big part of what I believe to be fundamental to human development and brain development, but that's not something that I would specifically provide advice for. I would limit my recommendations personally to avoid ultra-processed factory foods. The one thing that I would advocate, again, as far as early development, I'm not fussed if it's bottle fed or breastfed. I am an advocate of natural breast milk rather than factory ultra-processed formula. So we know infants who feed predominantly on formula have a much higher reflux rate than infants who feed on natural breast milk. And that's independent on whether it's fed directly off the breast or via a bottle. And we know that infants who reflux have a much higher tendency for adenoid overgrowth, which tends to lead to airway disorders. The other thing that I am a strong believer in is to avoid spoon feeding infants. Spoons are fine for infants or young children to use, so long as they feed themselves with it. But I am against adults spoon feeding infants. It's my belief that spoon feeding too early forces a unfavorable change in the swallow pattern and disrupts the natural transition from a suckle to a swallow and forces a suck swallow. I know it's common practice in most societies today to spoon feed babies from about 6 months of age to get them accustomed to different foods so that allergies and stuff are reduced. But I don't believe that's helpful to transitioning an infant swallow pattern correctly. Spoons can be used by babies so long as they hold it themselves. But the reality is most people shouldn't be using spoons to feed until they've got enough teeth to chew on. Molar teeth to chew. Next question is, can you give us food recommendations that you have found kids are able to tolerate with appliances in place? I would like to give a list out to parents to help, but I know we can't give nutritional advice, as far as dietary advice, but list of foods item kids complain less about. My only advice regarding foods is to avoid super sticky foods. So no toffees and minties and chewing gum, and anything that's ultra tacky and sticky to avoid. The plates, everything else, I'm not worried about. Soft foods for the first couple of weeks, then after that, anything and everything other than super sticky, tacky foods. Okay, next question is, when we are done with active expansion and patient is only wearing the appliances passively as retainers and doing go flex, should patients be eating with appliances in place? So when we are at retention stage where we are moving out of wearing plates during the day, we should have reached a stage where the occlusion is reasonable and we are training for a correct swallow pattern with the GoFX exercises. When we are training for GoFX, it has to be done without appliances in the mouth. Right? You can't train a child to do GoFX with any appliances that we use in the mouth. So GoFX is specifically training a child to relearn a correct swallow. And a correct swallow encompasses, saliva, liquids, and solid foods. So, of course, when we're at retention, nighttime only, when we're training for GoFX, we should not be eating with plates. Because we can't actually get a correct swallow with plates in place. So once we are ready for GoFX training, once we've mastered GoFX, we should be eating without plates and beginning the process of not having plates in the mouth during the day at all. So yeah, and when we start GoFX training, we have to begin GoPEX training again, but without plates. If that helps. All right. So when you start GoFX, we move to GoPEX without plates. And GoPEX includes the chewing at the dinner table exercises without plates. If that helps clarify things. Next question. How to check for nasal hypotonia? So nasal hypotonia is to see if the nostrils collapse with inspiration. So we check by having them seal their lips and breathe in and out through their nose. And we're just looking to see if the nostrils collapse when they breathe in. So nasal hypotonia is a collapse of the nares or the nasal opening on inspiration. So I have the child close their mouth and then breathe in and out fairly heavily through their nose and just watch to see if the nostrils collapse or not. Next question. When a patient refuses to see ENT for severe tonsillitis and requests the postural orthodontics first, do we still insist for ENT treatment first? What to expect if we start treatment first? So everything is degrees of severity. If a patient has infective tonsils, then there are primary care issues that have to be managed first. It's very rare that a parent will refuse ENT assistance if they have a child with severe tonsillitis. All right, severe tonsillitis is life-threatening because it's infection, it's swelling, it damages the airway, it can spread into the airway. So very rarely will a parent not seek medical attention when their child has severe tonsillitis. Most likely, the case scenario is they'll go see their medical practitioner, the primary care physician, who will prescribe antibiotics, and the antibiotics will calm it down. They'll probably say go see ENT, then because the antibiotics works, child settles down, no one bothers to do anything more than that, and then it flares up again. So obviously, you can't just keep feeding kids antibiotics. If it's just once a year, very often no one will do anything beyond that. But if it's 3 times a year or more, then the GPs generally insist patients go see ENT because it's now recurrent effective tonsillitis. That said, a lot of parents still won't see ENT and will continue to see their GPs for antibiotics, and the GPs, well, half the time you see a different doctor each time you turn up the clinic, so they really don't have the time to counsel you to see the surgeon. They just write you a script and send you on your way. So it's a matter of helping the parents understand that primary care is important, is the most important thing to seek attention for. What you do is there to help with the orthodontic dental relationship. But if they have infection, if they have airway obstructions, then what you do not only is unsustainable, but will add to the burden of the airway blockage, because you're sticking things into a kid's mouth that further makes them struggle with their airway. And the reality is kids who are severe with tonsils or adenoids blockages can't breathe because of airway obstructions and are sick because of the infection in their throat, and almost never tolerate impressions nor appliances in their mouth. Where is it common where we have to juggle? The class 3 patient who has big tonsils, who has big tonsils but has no infection in their tonsils. These are the patients where often the mandibular development is reasonable, but the maxilla is small and compressed or in reverse sagittal relationship. In those cases, we still step in, expand the maxilla, but my advice always is if you don't get the tonsils managed, the class 3 tends to continue to run away from us, and the changes are very difficult to improve. So that's generally my experience with enlarged tonsils. Okay. Next question. If a patient with severe class 2 division 1 unable to have lip seal, will twin block together GoPex help for initial stage of postural orthodontics? So my management of severe class 2 division 1 patients is different to what I teach in postural orthodontics, because severe class 2 division 1 skeletal relationships are outside of what you're going to be able to resolve with expanders and postural exercises. It's standard of care in many countries to use twin block. Twin block is an appliance that has been researched extensively and shown to be very effective in reducing dental alveolar imbalances in class 2 division 1 relationships in particular, but it has not been successful for changing skeletal relationships. But certainly if you're going to use that appliance, by all means, follow the protocols that are advocated by whoever's teaching you to use that system. But there's no downside in adding in the GoPex exercises. once you have reduced the overjet relationship. So certainly, GoPEX is going to be very difficult for a child who can't close their mouth properly because of the big discrepancy in AP. But if you can reduce that discrepancy, then once you have a more manageable bite relationship, then by all means you can supplement whatever treatment you're doing with changes in posture. So even though I'm not here to teach you twin block or other forms of mechanics, I'm here to teach you fixed orthodontics or fixed appliances. Postural improvement can benefit everyone universally. So you don't have to use my system, but there is all upside to incorporating changes that favor good posture in any of the patients that you look after. So irrespective of the systems that you choose to use for the treatment of the children that you look after, please consider using the GoPEX exercises for everyone. At the end of the day, whatever mechanics you use, whatever system you use, your outcomes will be more favorable if you can improve the child's posture. And GoPEX ultimately is control of the mouth for good function and good posture through the mechanism of eating and speaking. If we look at it from the simplest, the most simplistic viewpoint, GoPEX is nothing more than good table manners and good speaking manners. So by all means, please use GoPEX to help, whatever treatment system they use. What was the next question? If a patient with severe, yeah, so hopefully that answers your question. When there's a severe skeletal imbalance, you can't actually train a child to do the exercises properly, but if you use whatever system you use to reduce the discrepancy, once you've reduced the discrepancy, then you can get a reasonable bite relationship and a manageable amount of lip seal, then yeah, use the exercises to help you.
Okay, I don't think there's any other questions. We got 2, 3, 4 minutes left. If anyone has a last question, feel free to either raise your hand if you want to talk and ask your questions over the microphone, audio, or we'll wait another 30, 40 seconds to see if, or just type yes if you have a question and we'll wait for you to type it. Otherwise, we'll let Simon have some lunch. Just a quick notification for those of you, I think all of you here are part of the case study vault. We've got the full transcripts of all our advanced training. Transcripts are uploaded. If you log into Teachable for our advanced phase 1, 2, lab day, clinical day, and our mentoring calls. So you can search cases much more easily, search for certain topics, whether it's about photography or where to buy appliances, etc. Hey Ella, Dr. Ella, welcome. Good that you could join us at 3, 4 a.m. from Romania. Do you want to have we could unmute and you want to have a quick chat with Simon? Allow you to talk. There you go. I've just promoted you to join our panel. Dr. Ella from Romania.
Yeah.
You,
Can you hear
hi,
me?
we can
Hi.
hear you.
Hello.
I'll let you have a chat with
Yeah.
Simon.
Oh, hello.
Hello. So good to hear you. Thank you for all
Yeah.
your precious information and help that you offer to the dentists, orthodontists all over the world. You are doing an amazing, amazing job. And I
Oh, thank you.
appreciate and I'm so thankful. Thank you.
Thank you. Thank you. Do you have anything that you want to ask or anything you
No,
want to
just
discuss?
to listen to you. It's a great pleasure. Anytime I get the chance to listen to you, I'm very happy.
Oh, good to hear. Good to hear.
Perfect. Thanks, Ella.
Thank
All
you.
right. So, yeah, do join us on the weekend if you can. There's the live mentoring calls.
Yes, I will.
Yeah, I emailed you the times. You just do a bit of a
Great. Yes.
conversion from
Yes.
I think the Melbourne 9 p.m. uh is I think midday for you in Romania. What time? Romania is
That's
uh
perfect. Yeah.
yeah.
Great.
So just do a double check yourself, but I
Yes,
believe
I will.
it's 12 p.m. on Saturday. So
Great.
Simon will be on for a couple of hours. Unfortunately, the Sunday session is not a good time for you. That's probably your 1 a.m. or something. But you can more than welcome to join both and listen in if you can. And they're uploaded, recorded, and transcribed
Okay.
now.
Great.
So we've got a nice case study vault that you can all tap into. All right,
Thank you
terrific.
so
I don't
much.
think there's. Sorry, go ahead. Do you have a question? No, all good. All right. All right, terrific. Thank you, everyone. Thank you, Simon. Have a good day.
Thanks, guys. Bye-bye.
Bye.
Bye, Ella.